Thanks, Prasan. Good morning, everyone. I always wanted to do this, but I can't. And I see why it's not done more often, right? Because you want to say our next speaker requires no introduction, and you just go and sit down. But then that seems not very polite. But this is really true here. So Gordon Guyatt is a distinguished professor at McMaster University, um, uh, who is an inspiration in a number of ways for people in this room. So his trajectory is very unusual. He uh, was born in Hamilton, Ontario, and was grew up in Hamilton, Ontario, and has developed and changed the world from Hamilton, Ontario. So he thinks he's one of the luckiest academics because he was able to get the opportunities that he needed and shaped his career and shaped our careers without really moving too far away from where he was born. This despite taking a very unusual trajectory. Interested in English, and some of us had the opportunity last afternoon to enjoy his great command of communication and writing and speaking, and in psychology. He chose to maybe do something more interesting, he thought, and go into medicine. But he had not done any of the pre-medical things that you normally would do, like anatomy and all those sort of things. And he was lucky enough that one of the few medical schools that would take such an unusual student was right there in Hamilton at McMaster University. Having done medicine there, he was nudged to become interested in this nascent field of clinical epidemiology, which was being essentially born and right there at McMaster University. And so he joined a small group of pioneers who took some of the tools of epidemiology and applied it to clinical practice. And without much of a commitment to research, he has evolved over the next few years, few decades, into one of the most cited, published and cited scientists in the history of science, in the history, let alone the history of medicine. With almost 2,000 publications and 500,000 citations, Gordon stands among a very, very small group of investigators who have made a significant academic impact. But it's rare that academicians have such broad impact on the way people think and act. 33 years ago, when he was in charge of education and being a program director for internal medicine residents, he wanted to announce to the residents that things were going to be different and that they would learn to be making decisions based on the best available science, and thus started a paradigm shift in medicine and medical thinking that later became known as evidence-based medicine, a term that he coined. And since his beginning of his career, he's made other impacts that perhaps are not as well recognized as having coined evidence-based medicine and promoted, which include promoting the use of patient-reported outcomes in medicine, the development of methodological improvements, particularly for systematic reviews or randomized trials, and perhaps in another defining component of his career, developing methods for the rigorous development of clinical practice guidelines and the GRADE approach to clinical practice guidelines, which has had a very interesting effect of coming back to the basics of evidence-based medicine and codify what evidence-based medicine is about in practice. When we think about, so in addition to being a gifted researcher and a gifted communicator, a gifted educator, Gordon is also a gifted mentor. And he's mentored hundreds of people from around the world in careers of great success. And yesterday at the party, Juan Pablo was taking a picture, one of many pictures showing the multiple generations of mentorship that Gordon gets to potentially claim if he chooses to. But these are generations of mentors and mentees that hold generation after generation some of the values that I learned from Gordon when I had the opportunity to spend 2 years with him at McMaster. Chief among them is generosity and integrity. And those are two of the values that, as you know, led to the care unit formation. So those are things that I learned directly from Gordon. And when you're such a good mentor, you become also a close friend and a lifelong friend. And I'm very, very lucky to have learned from Gordon, have Gordon as a mentor, and have Gordon as a friend. And I think we're all very lucky to have him as this morning's presenter, Gordon Guyatt.
Thanks very much. Victor has recently been complaining to me about the big fuss people make introducing those to places. Well, we've learned much from his own experience. That was a lovely introduction, although I might have preferred, he needs no introduction, thank you, Gordon. I have to figure out how to change the slides here.
So it's actually this keyboard right here.
This keyboard.
Yes, this one has a ghost in it, so we don't use it.
Right, thank you. Thank you for helping me with the microphone. Okay, EBM and care that fits.
No, it's not working.
Don't think so.
No. Should be up, there we go.
Excellent. Okay, I'm going to talk about two challenges. Sorry? They still cannot hear in the back. What do I have to do here? I have to stand. Okay, okay, how's this? Okay. All right, all right.
Maintenance, man. All right, here we go.
Okay, disadvantages of being the first speaker of the day. Okay, two challenges for evidence-based medicine and care that fits, evidence for delivering kind care, and the limitations and misapplication of guidelines. So I'm going to start with some questions for you about evidence and kind care. 3 short stories from my clinical practice and 1 longer one, and then guideline limitations. So I have to acknowledge Victor and his wonderful book. And it really was, when Victor asked me to do this, I said, Gordon, I said, Victor, I do not feel really comfortable with this. And Victor said, I will help you. And he gave me a lot of help and actually a major education in language and the use of language and what I could do in this talk. So thanks to Victor for great help in having me prepare this talk. So EBM is about randomized trials, some people think. No, it is about the best evidence available to address patient problems. And high quality evidence can sometimes come from observational studies, such as interventions with huge effects, hip replacement, dialysis, ventilation, and so on, in which we have high certainty in the evidence, despite not having randomized trials. And then there are other issues in which we are pretty confident, even though we do not have formal observational studies at all and just go on the basis of indirect evidence. We all know that we'd better do a history and physical examination with our patients, and ideally a skilled history and physical examination, although if you looked for direct evidence to support that, you would not find it. So the question is, what evidence might we bring to bear on the issue of kind in careful and kind care? Well, Victor had to educate me about what we meant by the kind and careful and kind care. And he said, Gordon, it does not mean being nice. Rather, it means being respectful of people's time, energy, and attention, and perhaps identifying their needs and working hard to meet them. So, is it possible to get high quality evidence about the impact of kindness in delivering care? Victor also educated me about my poor understanding of the meaning of empathy. I thought it implied action that one might do. But Victor informed me no, empathy is just what you feel for the other person. So with the first action, if one is being empathetic and delivering care, might be in conveying to the patient your empathetic feelings about them. So the question for you, my first question to you is who or what does a better job of conveying empathy? And the response options are for sure humans, probably bots, for sure bots. Okay. Who thinks for sure humans? One, a couple of people. Huh? Probably humans. Oh, most people probably. Probably the bots. A couple of people, probably the bots. Anybody think for sure the bots? Nobody's for sure the bots. Well, I think there's only preliminary evidence about the matter, but I will show you the preliminary evidence. So what these investigators did is they took public, non-identifiable questions from a social media forum. They randomly drew 195 exchanges, verified that it was really a physician who had responded. And then they gave the questions to the original questions to the chatbots in refresh sessions. And 3 physicians rated first of all, the overall quality, and then the expression of empathy in the bots versus the clinicians. And the results of this, this has stopped working. Oh, I pulled my thing. Okay, sorry. That's better. Okay, the results of this generated some attention in various media. ChatGPT rated better than real doctors for empathy and advice. The bedside manner is better with the AI, more compassion, and so on. And here are the results. Here are the response options from very good to very poor. And in quality ratings, you can see that the bots do better. And in empathy ratings, there's very little overlap in the distribution between the bots and the clinicians. So most of you, when you asked who's better, at least on the basis of this evidence, however preliminary it is, the bots are better at showing empathy. So, okay, empathy is feeling for the other. Compassion, Victor taught me the distinction between empathy and compassion. Empathy is what you feel. Compassion is acting on the basis, perhaps, of your empathy. So kindness, conveying empathy, compassion, care that fits, all seems to me closely related concepts. Now, when we think about the kind in careful and kind care, should we care about outcomes? 2 response options. Kind care is an end in itself, never mind the outcomes. We should be doing kind care for itself. Or we must think about the outcomes and think perhaps of measuring the outcomes of the kind care we deliver. Who thinks kind care end in itself? Okay. Who thinks must think about the outcomes? Okay. Split, I'd say 2/3 kind care end in itself. However, I'm going to talk about at least the possibility that maybe we should be thinking about the outcomes. So one could do a randomized trial of kind care. You need to develop an instrument to measure the delivery of kind care, figure out how to teach it, randomize clinicians to training in delivering kind care or not doing so, and document the differences in kindness now that you've found out how to measure it, and in outcomes. What outcomes would you include in such a trial? Question to you. Now here, people have to be not so shy. Anybody want to shout out an outcome that you should include in a randomized trial of teaching people to deliver kind care or leaving it to usual medical training? Quality of life. Okay, good. Any others?
Patient satisfaction.
Patient satisfaction. Okay, good. Any others? I think those are the key, particularly in my notion, the quality of life. So short-term and long-term quality of life. Okay, I'm going to now describe some patients that I saw. I'm a secondary care general internist, which means I work in the hospital. I get referrals from the emergency room to my internal medicine service, who are often demented people who are not coping, and they're in the hospital now looking for an alternative living arrangement. So how to help them during a hospital stay? Well, one thing that I've started to do, and again, I owe to Victor, I think I only started to do this on a consistent basis after I read Why We Revolved. And I thought, okay, Victor has a vision of kind care that I found compelling. So small thing to do, ask people about their past life. So I usually do that. And the possibility, many of my patients in this situation say, I do not want to go to a long care institution. Is it possible to ever rescue them from that fate that they are not very happy about? Okay, these are not pictures of the real patients that I saw, but I took them off the internet, and they sort of look like the patients I'm going to talk to you about. So this woman had been born in the Caribbean, and she came to Canada as a young woman in her 20s. And I said, just talking to her about that, and I said, what made you come to Canada? The Caribbean is such a nice place. It's warm, it's lovely, and you come to this environment where the winters are miserable. They're actually less miserable than it was when she came and I was, when we were both young, because of global warming. The winters are not nearly so cold. But when she arrived, you would go through a few months, snow on the ground, always well below freezing. And she said, I didn't know till I got here. Bit of a surprise. Okay, my second patient was an interesting guy. I remember his name was Jack. And Jack, I came in, started to talk about his past life, and he told me a story. His story that he told me, he did not tell me all at once. As I came back in my first number of days with him, I got the story gradually as we went along, day by day. Well, Jack was from Britain, and I didn't even know this at the start. Britain sent quite a contingent of people to Vietnam to support the Americans. And he was one of the people who went to Vietnam to fight the Viet Cong. And he was in a group of soldiers who went out on a night patrol. And when they were on night patrol, they walked down the Ho Chi Minh Trail, which I found out was just a little highway. And they walked, there was quite a space between them, but they were walking, looking for Viet Cong, hiding around, seeing what they could do. Well, Jack was surprised by a Viet Cong soldier jumping out of the forest around the Ho Chi Minh Trail, running up and taking a knife and slashing him in the abdomen. And 50 years or whatever it was later, that scar is an impressive scar. This was no light touch, that the Viet Cong. Well, the adrenaline must have been pumping, because despite the fact of just being slashed, he pulled out his knife and slit the guy's throat. Guy collapses dead. Jack goes, sits down by a tree, leans on a tree, waits for his next colleague to come along. His next colleague comes along, sees what happens, and says, okay, got to get you to some place for care. They were sufficiently isolated that it was a 2-day trip, with Jack having his arm over the guy's shoulder, and they made it, and they had arranged for a helicopter to come and pick them up. So now they're sitting, waiting, they're getting to the clearing where the helicopter is going to land. And if any of you have ever got close to a helicopter is noisy as it is landing. So Jack was shouting to his colleague who was sitting beside him, and suddenly he realized his colleague was not responding. He looked over at his colleague and saw that he'd been shot through the forehead and was dead. Helicopter landed. Jack made it quickly over to the helicopter and was then taken to some place where he had some rehabilitation and subsequently came back and fought some more in Vietnam. So that was the story that Jack told me over a few days, perhaps the most dramatic story I've ever heard from one of my patients. He told the story very well. He was quite articulate and he was charming. He was charming. And yet he'd never been married. As far as I can tell, the whole time, nobody came to see him. He seemed very isolated. So it was something I thought, well, I've given him a week of companionship. This gentleman worked as doing some heavy machinery in a steel plant. Hamilton was a steel town when I was growing up. And he was now 70-ish. He was living in a rooming house with another 5 guys. He had been admitted a week before. He had been admitted a couple of weeks before I took care of him, but he had signed himself out from the hospital. He was a diabetic. It was clear he didn't know how to use his insulin. For the second admission, he was found unconscious on the sidewalk and he was brought in. When I first saw him, I wasn't sure of his mental status. He was talking, told me the stories, told me what happened. And I said, but look, this time don't sign yourself out. And he says, oh, doctor, no, I've learned my lesson. I will not sign myself out. The next day I come out, the nurse says, oh, the guy wants to sign himself out. So I go in, I say, no, come on, we decided we would not sign yourself. You would not sign yourself out. So he says, oh yeah, okay, I won't sign myself out. Next day I come up, same thing that happens. Okay, he's signing himself out again. So now I said, look, you cannot use your insulin. Do you think you can use your insulin? You know you cannot use your insulin. And if you don't do it, that'll kill you. And if you do it and give too much, that will kill you. So you do not know how to use your insulin. You need to hang around. Oh yeah, oh yeah. Next day, I thought the guy, as it turns out, he had the dementia that fluctuates a lot. The next time I came in, he was lying on his bed naked except for his diaper, and he didn't know where he was, which was quite a different picture. Well, the day after that, he was back looking more or less like he did in the first day. But every time, but by the latter part of my working with him, he was no longer trying to sign himself out. And every day I would come in and I would reinforce it, but he was no longer trying to sign himself out. So my accomplishment over that time was to get Jack to agree, sorry, his name wasn't Jack, to get this gentleman to agree to stay in hospital. And my final story is a little longer. This woman, whose name I do remember, her name was Mabel, and I was coming on clinical service and I took the elevator up to the floor that I was working and I got off the elevator. And I saw Mabel there conversing with a young woman who was sitting in the hall. I don't know how they got there, but, and Mabel was saying, my doctors do not come to visit me. When they do come in, I ask them a question. They never answer my questions. Nobody comes to visit me. This is a very frustrating situation. And the woman beside her says, well, it doesn't sound good, but it can't be that bad for you. I see you very often talking to your neighbor, and the two of you are laughing and seem to be enjoying yourself. Mabel says, what's wrong with laughing? What are you criticizing me for laughing? You know, come on, get with it. And I said, I wonder if this woman is going to be one of my patients. Well, As it turns out, Mabel was one of my patients. She was a very interesting woman. I picked this picture. I don't know what if you would agree. This seems like a quite attractive older woman to me. Mabel was quite attractive, and you could see when she was young, she would have been very attractive. She had 4 kids with 4 different men. Okay, so she had a quite an interesting background. And she had dementia is very cognitive impairment, very variable. She had a particular limitation of short-term memory. She could not remember things. She would forget. So it took her several days. When I saw it took several days before she would recognize me at all. And it would be very difficult for her to remember anything that happened in our interaction. But she could still read sophisticated stuff. She could have a high level of conversation. It was just a selective short-term memory problem. And so I started to write down when we had an interaction, the most important things I started to write down and leave it for her. But every day when I would come in and see Mabel, the conversation would be the same. Look, I can dress myself. I can feed myself. I can read and write. I can walk around. I can take care of myself. Why aren't you letting me go home? They're going to put me in an institution. And look, I can take care of myself perfectly well. No, Mabel, you can't they found out somewhere. They found out you really can't. So this went on every day for a few days. And then I thought, Mabel has a point. So every day at our hospital where I work, it's very nice. We have a multidisciplinary round, and there's the social workers and the physios and the OT and the nutritionist and so on. So everybody's together to talk. And there were 2 social workers in this group. And I went in and I said, how come, Mabel may have a plan. How was it that people decided that Mabel has to go to a long care institution? They were kind of evasive about the answer. So I thought about it. And I came back the next day and I said, show me the documentation that documents why Mabel can't go home. And they said, ooh, there was no documentation. So I said, okay, we got to get some documentation. Okay, we'll make an assessment. That's going to be that these things take weeks. All right. So at least we're going to make a proper assessment. Anyway, so one of the things I do, I'm not sure I would do this if I were delivering outpatient care, but my hospital stints are now 2 weeks now, sometimes 1 week. I always give my phone numbers out to the patients, and people wonder why isn't there trouble? There is never any problems, and it really facilitates care. With Mabel, there was only a little problem. That sometimes I'd seen her half an hour before, and I would get a phone call, and Mabel would say, "How come you aren't coming to see me today?" So that was a bit of a problem. But I was in Mabel's room, and something very fortunate happened. I came in, and Mabel was on the phone, and I said, "Mabel, who are you talking to?" And Mabel says, "I'm talking to my daughter." And I say, "Oh, Mabel, can I have a chat with your daughter?" Well, in the course of this chat, daughter tells me, "Oh, I live in Vancouver. Mabel's a long way, but I would like Mabel to live with me. That would be positive for me to have Mabel living with me." But I came to Hamilton. I talked to the social workers, and they said, "You can't have Mabel living with you. When you take her you work, you're out all day. You can't leave Mabel in the apartment all day by herself. And we can't get the care. It'll be 3 months before you get any help with care for Mabel, so you can't take her." Well, the daughter just accepted this and goes back to Vancouver. I say, "What's your financial situation? If you had the money for 3 months, you could hire somebody outside of the care that the public service provides." "Oh, well, really? Oh, didn't think about that." Apparently, the social workers did not raise that issue with her. So the next time, so she now has my number. Next time she gives me a call, she says, "Look, I thought about it. We have the money. I'd love to pay for care for Mabel. I've arranged with my brother. My brother is going to come out to pick up Mabel, take her back to Vancouver, and Mabel's now going to live with me. And I said, that's just great. So this was right near the end of my rotation. So I come and say goodbye to Mabel. And I say, Mabel, great, you're going to live with your daughter, no long care institution, beautiful. And Mabel says, now I'm getting emotional. Mabel says, you've really done something special for me. And I said, Mabel, this is just my job. And Mabel says, no, you've really done something special to me. And I felt that I had. So, does asking patients about their past life make any difference? Most of the time, very little. Sometimes, perhaps like with Jack, who the soldier, maybe a little. Did my interventions with Mabel make a difference? To me, no doubt, high quality evidence. This is like we make a joke about if somebody now takes a pill and you have an amputation and you take the pill and your arm grows back, you do not need a randomized trial. This is as certain to me that I made a difference in Mabel's life as that. So what are the lessons? We can focus EBM on our lens on interaction with the patients, stay alert, and sometimes make important differences. Final questions for you. Who here was trained as a clinician? Okay, almost everybody is trained as a clinician. Delivering kind care was part of your healthcare training. Definitely yes, well, a little, very little, not at all. Definitely yes. Okay, a couple of people. Well, a little. More people. Very little. A whole another bunch. Anybody not at all? Yes, not at all. So a pretty wide distribution. Delivering kind care should be an explicit part of healthcare training. Definitely yes. Okay, everybody's done. All right. Okay, that was end of part one of this presentation. We now move to part two of the presentation, which has to do with problems with guidelines. What are some of the problems with guidelines? They are typically focused on single conditions. So you have a guideline for your hypertension, a guideline for your diabetes, and a guideline for your osteoporosis, and so on. And that typically leads to, in the patients to whom I give care, the typical thing is they will come into the hospital literally on 10 medications. And in the work done here and in the work that Victor has been particularly concerned about, we have the burden that that places on patients. And the current guidelines just tell you, here's what you should do for all these conditions, and then people follow it, and it's with the outcome that I just described, with no guidance anywhere for how to prioritize with these. So clinician, if you want to prioritize, you figure it out, hopefully, with your patients. Second, as Victor has described to me, the guidelines are sometimes used by the people who are leading industrialized healthcare to engineer healthcare in ways that are not actually beneficial to the patients, and neglect. So guidelines neglect many issues importance to patients. I do not have a solution to these problems, but I want to tell you one, at least small contribution that a group with whom I work has made to this. So this was a paper that I was associated with, as was Victor, a framework for practical issues to inform shared decision-making and clinical guidelines. So this was inspired by thinking there are practical issues that are neglected in guidelines and sometimes neglected in care when in interacting with patients. So what the investigators here did, they identified generic categories of patient important practical issues from sampling 2 databases with patients with questions patients frequently ask. A health talk registry, large sample of patient experiences got from focus groups and standardized interviews, and what somebody calls option grids, decision aids that include patient experience in the form of frequently asked questions. And they used qualitative methods. I know very limited in my knowledge, but they use grounded theory, iterative coding of all the information engineered into themes. So what then? Magic App is a guideline authoring and publication platform. After choosing the final categories, it was integrated into the app in practical issues that can be put into evidence summaries supporting guidelines. And they took these presentation formats and thought, how can they develop them so that they hopefully would work well as decision aids? And then they did a feasibility check. One of the things this group, Making Great the Irresistible Choice, or MAGIC, that I am associated with, has a collaboration with the BMJ to provide BMJ rapid recommendations. So here's the overall picture that I've just described. They get the data sources, they extract the data, they get initial categories, modify them, group them to the final categories, and I'll show you more about the final categories in a moment. Generic framework, put it into Magic App, and then test it out in the BMJ rapid recommendations. So here are the categories: medical routine, tests and visits, procedure and device, recovery and adaptation, so on. Give me a second to look at the other categories. So they got 15 of these categories of practical issues that patients face. So you can, in terms of the decision aid part of it, you can present these 15 to the patient and they can say they want to know about the procedures and device. And so they pull up a few points about the procedure and device. Also in the, there's ways of presenting quantitative information that you see there with all these faces, 1,000 faces saying how many will have the outcome events and how many will not have the outcome events if they have the treatment. So user testing in 28 consultations, high satisfaction. These are consultations, physician and patient. The most of the time in these it was used, the pictographs were found, the patients found them to be intuitive. Navigation was easy, facilitated conversation. So as in qualitative research, you have some quotes that the investigator tells you from the patient. The information about practical issues was best and what matters to me on a day-to-day basis. Clinician. At the same time, it became clear that practical consequences were important for her, in particular, her travel to the doctor. And this was positive. Not sure if I had captured this without the decision aid. This is a good thing. Quote from the patient: I appreciated the text on practical consequences was short, or else I would start reading the small text. And another quote from the patient: but actually, I'd like to have some more information about why we're not taking any blood tests. What's really the reason for that? Why can't you measure how it is? So on. That quote was because the investigators found that when they presented the practical issues to the patients, not only did they pick out practical issue A, B, and C that they wanted to know about, it stimulated them to think about other practical issues, which they would then raise in interactions with their clinician. So seems to be a big success. So conclusions from the talk: evidence of caring interaction with patients, low quality evidence of perhaps frequent, maybe not so frequent, small benefits and quality of life. Very transient in most cases from the kind care that I can see myself trying to deliver in the context of these demented patients. Sometimes you may get fortunate, high quality evidence of large differences that the kind care makes. With respect to guidelines, big failures in multiple morbidity, misuse in industrialized care. The practical issues that I have told you about implemented in guidelines and in shared decision-making may be helpful. But if we're really going to address it, you know what we need: a patient revolution. Thanks very much. Now to take questions and comments.
So we have some good time for
Yes,
questions.
I was instructed to leave lots of time for questions.
Well, you followed your instructions well.
I did. Victor has found I'm very obedient when he is giving me.
Gordon,
You're the only one if you would have, if you would have heard the session yesterday.
Gordon, Gordon.
This
Yeah,
particular character is-
Gordon, thank you. This is JP. Wonderful, as always. I think you mentioned the impact of kind care, mostly focusing on the patient's perspective. You did not tell us, except with your almost tears, that actually impacted you quite a bit. So,
Yes, so, oh, thank you, Victor. So, the, this is clearly an aspect that will never be captured when the bot is giving the empathetic care. So yes, there is something that is going on between the patient and the physician. So that final interaction with Mabel that moved me so much, Mabel was, Mabel wanted to convey to me her appreciation, and her appreciation was very moving to me. So there was something in that interaction between Mabel and me at that moment, which I put a very high value on, and I suspect Mabel might also have put a high value on it. So something is happening in the interaction when you deliver kind care beyond the quality of outcome, beyond the quality of care. Maybe that should be something else that one could measure. These meaningful experiences. And when we think back on our lives, what do we think back in our lives? What is most important to our lives? It is special interactions with people are very high on the list of what's important in our lives. And that's something, I think you're absolutely right, that emerges from the delivery of kind care.
Oh, hi, I'm Camila. Thanks for your talk. It was amazing. To me, it's logical. This is the type of care that we should provide to the patients, but we're still failing on doing this. Why do you think this is happening? Can we blame just the medical education, or are we blaming the health, the health companies? Why are we still not able to provide this kind care with evidence-based medicine combined?
Okay, so being an evidence-based medicine guy, I immediately have to acknowledge my limitations in this because if there are studies out there, as I suspect there are, about barriers and facilitators for delivering kind care, I have not read them. And I suspect that that if you really wanted an answer to your question, you would have to do studies of barriers and facilitators to delivering kind care. So what I say is anything I say is probably of limited value because that's actually what we would need. And if they're out there, which they may be, I haven't read them. However, to speculate, number one, you saw what happened when I asked this audience about whether delivering kind care had been part of their training. And it was a distribution, but most of the people were in the very little or not at all. And if it's not there as part of your education, I could have asked, maybe I will ask another question. How many of you, it sounds like most of you, it was not a formal part that say, okay, here we're going to talk about delivering kind care. How many of you would say, if you think back on your role models and the people who were educating you, how many think that a substantial proportion were consistently delivering kind care? Very few. How many think that quite a few were consistently delivering kind care? Now a little more. How many of you think that only very few of your role models were consistently delivering kind care? Okay, that's probably the majority. Okay, so what determines who we end up as clinicians? I think a large extent it is our role models and what you see. People pick up in many cases, perhaps the majority of what they see. And what we've just heard, which I would think would be general, that for most of us in our training, most of the clinicians that we had as role models were not delivering kind care. And so that would be, so it's not formally taught by and large, it's not consistently practiced by and large. So, and personally, that's enough to explain why it's not happening as far as I can see. But you have system things, you have the fact that it takes time. To physicians, when I go around the world, there is one question that I get the same answer to in 100% of my audiences wherever I go. And that question is, do you have enough time to deliver optimal care with your patients? Everybody says no, okay? Every doctor in the world that I've asked this question, the hands all go up, no, I do not, okay? So time constraints and what you get rewarded for. I don't know how it feels from the stories that I've heard, how it feels delivering care in the United States, perhaps particularly in outpatient settings. You do not feel like you're going to get rewarded for delivering kind care. So there are system constraints as well. So plenty of reasons why it's not happening.
So you mentioned training, lack of time, and you alluded to systems issues, particularly in the US. I think it's not just that we're not encouraged to deliver kind care, we're actually punished for it. So if you've spent time on prior auths and trying to justify your patient still being in the hospital or needing another outpatient visit, if it's not driven by EBM guidelines, click boxes, we really are punished. How do we go after that?
Oh, I react the way I did there by you have now, as an EBM guy, I'm now regularly, when asked questions, I immediately identify questions that I'm completely unqualified to address, okay? And this was such a question. I don't even know which social science, whether it's social anthropology or sociology or psychology or political science, those are the sort of expertise I would have thought that would have been needed to address your question. And I have none of these. I can't even identify which is the best discipline that should be addressing this. So except all I do know is that the best thoughts about how we might go about it are in Victor's Patient Revolution.
Thank you so much for your talk, and forgive me for the ramble that's about to come. I haven't coherently have my thoughts in my head, but
Okay, I expect the next couple of minutes is going to be some entertainment for me. Go ahead.
I promised entertainment. So I guess it's complicated, and you know, I try to think of my experience and the experience of many of us who are relatively young and healthy in healthcare. When we visit with a doctor, I actually talk with my doctor and have a nice relationship, and he asks about my family, and I get the care that we're describing here. And I think a lot of us may get that actually. I think maybe the challenge comes when we start having conditions, illnesses, which increases uncertainty in the conversation and in the visit. Now the clinician's incentive has changed a little bit because they want to reduce this uncertainty and they want to use the guidelines as a tool to help them. So their incentive is about trying to identify sure answers, sure prognosis, sure treatments, and then the focus on the person. Maybe that starts dissipating, it becomes secondary. And so if you have many conditions, the person disappears. I don't know whether or not that, maybe that's just a ramble, but just as we're talking and I'm trying to think, it's maybe that the incentives, there's misalignment there.
Quite possibly. We've gone even farther away from any expertise that I have because I haven't done outpatient care for 30 years. So my care is strictly inpatient where the dynamics are altogether different. Interesting hypothesis. And for those of you, your colleagues who do deliver outpatient care, it would be a nice hypothesis to start discussing with them.
Gordon, in the question we heard before, there was a very subtle proposition, which was that this form of care stands in contrast with what evidence-based medicine will tell you to do. So I know you've made the case, and I think very eloquently, but perhaps um, uh, when do you see, or when you were, when the evidence-based medicine was becoming, um, at what point were there stresses of between this idea of responding to the needs and desires and challenges and goals and priorities of each person and what is right for this person versus that challenge of figuring out what's right for people like this one, which is the kind of answer that we normally get from randomized trials and the kind of answer that guideline groups are formulating to help people that have no time to be individualizing in depth.
Okay, so first of all, if you go back to the first writings, what I call the EBM Manifesto in JAMA in 1992, you will see nothing that relates to any of the individual patient perspective and nothing about values and preferences. And when we were writing and thinking at the time, the locus of decision-making was always on the physician. And we were starting with the notion that evidence would direct you in your care. Well, as it turns out, it was when we started practicing this on the wards and outpatient clinics, and we said, okay, here are the benefits and here are the downsides. And the penny drops. It wasn't there at the beginning, unbelievably looking back in a way. The penny drops that there are trade-offs, and it depends on the value you put into the positive outcomes and the value you put into the negative outcomes. And so then the lights go on and we come up with what we now call the third principle of evidence-based medicine, that evidence never tells you what to do. It's evidence in the context of values and preferences. And then when GRADE come along and we define strong and conditional or weak recommendations. Conditional and weak recommendations recognize that the values and preferences of people are different, and conditional recommendations within the GRADE framework imply, mandate, in fact, shared decision-making with the patients, which says that's got to be done attending to the needs of the individual. But I'm sure we have not, in general, in the EBM movement, emphasized that as much as we could have and should have. I'm sure of that. And what it took to really bring that into EBM in the big way was a visionary who saw this and who was put that out in front repeatedly in his writings and work and led other people to do that, and that's Victor Montori.
Thank you, Gordon. I was wondering if you could reflect a little bit on your observation that that final conversation with Mabel yielded high quality evidence that this was the right thing to do, because I believe that it did, and I believe that you believe that it did. But I'm interested in how that sort of evidence might find its way into, say, the production of guidelines for practice, and what sorts of pathways or manifestations that might take.
If you take, here's the most extreme, cardiac resuscitation after cardiac arrest. It used to be 100% of the people were dead, and now a few of them survive. But if you take the ones we usually throw out, hip replacement for osteoarthritis, ventilating people whose PCO2 is rising and they're about to die of respiratory failure, dialysis for renal failure, epinephrine for anaphylactic shock, insulin for diabetic ketoacidosis. What do all these things have in common? They have in common extremely large effect sizes. And for most of them, there aren't even observational studies showing large effect sizes because it's so obvious to people that there's a large effect size that it would be silly, people would find it silly to even do the observational studies to demonstrate. So we do have, fortunately, we do have intuitive notions on the basis of our experience of things that they used to go always, they went badly, and now at least sometimes they go well because of interventions that we have to people. So, and nobody, when we use these examples, say, show us the study. Nobody says that, right? Because it is sufficiently obvious to all of us, to clinicians who have any experience, that these are that these things have large effects, and and when we teach it, we say large effects. But for most of them, we can't point to studies showing large effects. Everybody just knows it's large effects, this would be. I would put the Mabel story in this category. Nobody, if I tell the story, would say, "Oh, I'm not so sure Mabel was better off living with her daughter." Okay. And nobody would say the path of what was going to happen had I not intervened was very clear, and what happened was completely different. And I think we can trust one another that when you hear and it's analogous to me of the extreme was growing the new limb, but it's analogous to me of what clinicians have seen with the interventions I just talked about, where nobody questions the magnitude of the effect and the certainty of the causal relationship. Stories like this fit into the same thing that you tell people the story and they see it.
Gordon, this will be a little bit on the side, but one thing that we have in common in this room, all of us, is that we survived so far the COVID pandemic. And not only the COVID pandemic, but and maybe some of us in the room, maybe to some extent affected what has been called long COVID, right? So some long-term health consequences attributed to the exposure to COVID. That was a new threat. Difficult to be evidence-based about it because there was no direct evidence about how to handle that threat. And yet we had to act. And
Yet what?
we had to act. We had to do something about it. And I'm perhaps going back to Paul's question about uncertainty and how does an evidence-based medicine approach helps us deal with uncertainty. In that case, it was a biological uncertainty. In some of the cases that we see in the outpatient setting, maybe biographical uncertainty. You're not really sure what is appropriate for this person. Do you have reflections about what you have learned? Because the COVID pandemic also happened, good 30 years into evidence-based medicine. I know that will be the subject of a whole talk, but in a few lines, what's your take about how evidence-based medicine fared during the COVID pandemic, and maybe one or two things that we can all take back from that experience?
Okay, well, not sure of the fundamental thrust of the question, but as to how we fare, it seems two parts. How did evidence-based medicine fare, and making decisions about uncertainty, which seem two separate topics. So I'll try to address both. How did EBM fare? With respect to treatments, extremely well. I talk about the international EBM community. We started randomized trials very quickly. We used new adapted designs, getting them going right away. The adapted designs allowed us to test one treatment after another treatment after another treatment. A couple of years into it, we had 3 classes of medication that were undoubtedly effective in non-severe COVID, and 3 different classes of medications that we knew were effective in severe and critical COVID. Very rapid development. Besides which the vaccines, very rapid, extraordinary development of effective vaccines. So in terms of coming up with the treatments, great. We also learned to summarize that evidence quickly. We created teams. There were 2 teams around the world, one at McMaster, which process the randomized trials very quickly, to do living network meta-analyses, sometimes processing 20 trials a week, to get the evidence summaries out. And also did overall quite a good job of translating those evidence summaries into guidelines. I've done tons of work with the WHO on their COVID guidelines, and ours were informed by the master network meta-analysis. So we had this continual feed of high quality current evidence to create the guidelines. So those, I would say, I consider that these big successes of EBM. And if we can keep it, if we now cannot go back to the way we used to do things, then and keep this up, that would be great. In terms of acting under uncertainty, it seems to me anytime there's a lot of uncertainty, values and preferences, always important, become absolutely preeminent. And pointing out that these are value and preference to sensitive decisions and what the values and preferences are is very illuminating. I'll give you one example. Somehow I've become someone who people consult about gender dysphoria and issues about evidence in gender dysphoria. And obviously very heated, and you have the CAMs. And to various audiences and to journalists, I say, okay, what we do about adolescence and access to treatments for adolescents has to do with values and preferences. And to me, the key values and preferences are, number one, harm reduction, okay? We know that sometimes people who transition using drugs or surgical procedures regret it, and that is awful when that happens, no question. So harm reduction on the one hand would restrict or forbid. The other is the value one places in the autonomy of the adolescent, if we're talking about adolescents, and that adolescent's family. And if you say, we don't care about the autonomy, the only thing we want is harm reduction, that would dictate one course of action. If you say we are less worried about harm reduction and we put an extremely high value on the autonomy of the adolescent and the family, that would have another. And that should be where the conversation should be. The conversation should be, once you've identified the key value and preference issues that drive decisions under uncertainty, that's where the conversation should be.
One last question, and then we're gonna go to break.
Thanks, Gordon. And so my previous question, the transgender care was on my mind, specifically when I asked you about that conversation with Mabel, in the sense that, so I'm reflecting on the Cass report in England that's essentially functioning as a guideline at this point governing clinical practice. And the sorts of evidence that would yield very high quality in terms of that would reflect the sort of insight that came out of the experience that you had with Mabel, the sort of stories that people tell of their real life experience of living with gender dysphoria and transition were systematically excluded from the guideline production process. So there were no representatives from the transgender community. Well, I won't say there were no, but people, anything that would paint a clear picture of what it is like for people living with gender dysphoria were removed from the description, didn't fold through into the final guideline. And so the power of that sort of evidence was removed because it was thought to be simply subjective. My point of tension is that in your experience, to say that it was simply subjective almost denies the reality of what you're experiencing with Mabel. I don't think I'm expressing this clearly, but maybe you can pick up the
Oh,
second.
I think you have been clear. So he would need properly done studies, and even this, I don't think, as I understand, have. But the issue, is it true that some people have profound regret about having undergone the transition? Yes, and there's no question about that. But the next issue is how many, okay? And it can't be, you can bring a few people in and have them talk about their experience, but the real issue is how many. And then you need a systematic way of determining that, which obviously the sources of the evidence are ultimately talking in the experience of the patients. But it's got to be, so certainly, and I'm certainly, there's some great successes. Now, that's even trickier perhaps, because you don't know what would have happened had they not transitioned. Maybe it was just maybe it was just time passes and they mature and they would have done well, transition or no transition. Or you're dealing with cognitive dissonance, okay? If I transition, I better believe that it was a good thing, because if it's not, man, I made a mistake. So there's complexity in that. So for sure, there should be some space for that. But in terms of the real issues of what, in those who did transition, what would have happened if they didn't, and in those don't, what would have happened if they did, which is at the heart of the issue. The selected narratives will be quite limited in informing what we really need to know in making the right decisions, the right policies.
Thank you, Gordon, so much for a wonderful session.